very cool program that once you've already got your RT and your associate's degree, you can do a completely online program to obtain your bachelor's. So, been doing that program for the last 2 years now, and this is my last class and my last project, and I will get to then say that I've got my bachelor's in science and radiographic sciences. So, thank you for being that last step for me. All right, we are going to talk about fractures today, and I know that you guys are all, this is first term, you guys are just starting out, but this is just some real general information about fractures and some things to keep in mind, especially when positioning a patient who might have that suspected fracture. All right, so you guys have all sorts of fancy screens, whichever one is close and good for you. The very first picture is going to show just a normal bone. We've got very nice smooth borders, no visible fractures or anything going on. Then you've got the transverse fracture. That's going to be just a completely straight across fracture. An oblique fracture follows suit with its name. It's a fracture that's going to come in at an oblique angle. The spiral fracture is a little bit hard to understand here on the picture, but if you consider taking a bone and twisting it from the top and the bottom, it's going to give you that spiral effect. And oftentimes it almost looks like a spiral staircase. It's got that real jagged all the way up and around the bone. Then a comminuted fracture is going to have multiple fragments. The segmental fracture is going to have a completely broken away piece of bone from both the anterior and distal aspects of the bone. An avulsion fracture, it says avulsed fracture, is where the tendon or ligament actually pulls away a piece of the bone. Very common when, like for my daughter's instance, she was going down the slide, there was a hole in the slide, she put her hand down to slow herself down, it caught her hand and pulled her fingers back, so she had multiple avulsion fractures where those tendons and ligaments attached to the bone. She didn't break the bone, but it pulled a portion of the bone away. So that is still a type of fracture. Then there's the impact fracture, which is where either the body or an object hits the bone and breaks the bone. Then the torus fracture, that has almost kind of like a buckle-looking appearance there at the center of the shaft on the picture, and that's the other common name for it, would be a buckle fracture. This is where the bone isn't actually broken, but the bone kind of pushes in and creates kind of crinkled edges. And then a green stick fracture. How many of you guys used to play with sticks when you were a kid? And you kind of try to break them, and if they were green, if they weren't dry wood, they would break just on one side, but not all the way through. I remember trying to break them, and you had to kind of twist them and jerk them around to actually get two pieces. So this is a green stick fracture, very similar in that it's broken, but it doesn't break all the way through. And that's very common in children or infants where their bones don't have the same density that an adult's bones have. So this is just kind of going over those terms and giving you a little bit more information about them. That comminuted fracture is where we have the 2 or more fragments. Segmental are going to be isolated by the distal and proximal lines. Yes?
Do you want a copy of this PowerPoint?
Yes.
I have emailed it to your instructor, and so I guess could you upload it to something or yeah? Okay.
Thank you.
Of course. And then that.
Trying to find the information.
Oh, yeah.
Where is it?
No, this is not something that's already been handed out. So definitely we can make sure that you guys have access to the information.
I appreciate it.
Of course. So that green stick was that bent but not broken all the way through. And then the torus or buckle fracture was where the cortex remains intact, but there is compaction of the surrounding bone. That's where it kind of had that crinkle effect in the middle. All right, that transverse fractures, that straight all the way across through the bone, completely through the bone. Oftentimes that is due to a direct hit of the bone. Then there was that oblique, follows suit with its name, a nice 45-degree angle across the length of the bone, usually due to angulation or compression. That spiral fracture that I gave you that example of almost a spiral staircase, that is caused by torsion or twisting of the bone. And then the avulsion fracture, where those small fragments are pulled away, usually by the tendon or ligament insertion points. These are other types of fractures that I did not have on that initial graphic. This would be a compression fracture where we see this a lot, especially in geriatric patients as their density kind of changes in their bone, that they'll have compression fractures in their vertebral bodies. So this is where there's a force from above and below and it compresses the bone. Depressed or depression fractures are often found in the skull or the tibial plateau. This is, and the weirdest one that I ever saw was a guy working on a job site. The guy was working on masonry work and doing some bricking. The guy walked underneath and was not wearing a helmet. A brick was dropped and actually then hit his skull and forced pieces of his skull bones down into his brain. He was walkie-talkie. It was the weirdest thing that I had ever seen. And so that's that depression fracture. We did an AP and a lateral skull, and you can see these little pieces of bone down into the brain tissue, and he ended up having to go in for surgery. Thankfully, none of those bone fragments hit anything that caused any severe damage. But that's that depression fracture. Stress or fatigue fractures are wear and tear fractures. They're very common in your feet and hands. And then you can have fractures that are caused by pathological things like tumors, infections, or metabolic bone diseases. So, we talked about all these classifications of fractures, but what terms do you guys know that are associated with fractures? Complete or incomplete? What was that? Right. So, other types of terms that are associated with fractures are going to be if they're displaced or non-displaced, or also can be referred to as undisplaced. This just really has to do with where the bone parts are. And then dislocations, bones that are no longer in contact with its normal articulation. Angulations can describe the position of the two fragments to one another. And then subluxations are when the bone is only partly unaligned from its normal articulation. So, we talked a little bit about fractures, but one of the things that you guys are going to see as x-ray techs a lot is patients who already know they have a fracture, and now they've been treated, and they're coming in to see, has it healed? So it's very important to do two 90-degree images. So when we talk about two 90-degree images, what are we talking about in most cases? Right, an AP and a lateral, or a PA and a lateral, depending on what part you're imaging. And then it's very important not to underexpose. But why? Why wouldn't we want to underexpose? Right. Right. And it's very important that we make sure that our technique is optimal because we're looking for very fine details of new bone growth. So as a bone heals, there's a bridge of callus that extends across the fractured fragments. The two opposing views are necessary to check for the healing of the fracture, and exposure needs to be ideal to show that fine detail. So here is a picture of a fractured tibia. The very first picture is the initial radiograph that was taken showing that fracture. The one in the middle actually shows a cast, and you can see how that kind of creates a little bit of like striation across the image. You can tell that there's an artifact there, and that is the cast. So this center image was taken to make sure that during casting, there wasn't any changes in the alignment of the fracture. Then the following one, where it labels that callus, shows that new bone growth. Do you see how subtle of a detail that is? So if you had underexposed, you would lose that detail of that new bone growth. We wouldn't be able to see it. And if you overexpose, meaning you were too high in your technique, you would blast right through it because it doesn't have that same density that the normal bone has. So it's very important when imaging fractures to make sure that you're getting a really good technique. So imaging patients with a possible fracture. Imaging is the sure way to diagnose and classify a fracture. So we, a lot of times, will get orders that say, rule out tibial fracture. You know, that's the reason for the exam, is to rule out a fracture. Patients may suspect that they have a fracture while others may not. I have patients all the time that swear up and down, oh, it's broken, I know it's broken, it's broken, it's broken, it's broken. You do their x-ray and it's beautiful. Beautiful bone density. You don't see anything. The site that I work at, I actually get the radiology reports back, and so I look right at what the radiologist says, and I can see he says it's beautiful. So it's kind of interesting that you have that patient that, oh, they're gung-ho for sure, it's broken, and it comes back it's not. And on the flip side, you have patients that say, I don't know why the doctor's doing this, I'm perfectly fine, there's nothing going on, and the minute their image comes up, you're just shocked that they're just happy as can be, talking to you, and, you know, not a problem. So anytime a fracture is suspected, you have to be careful with those patients. And that's where you kind of tie in some of this patient care things that you're learning. You're not going to manipulate the area. You're not, if the patient walks in and they're in that normal injured, you know, shoulder, arm injury position, you're not going to take them and fling their arm out because you want to get, you know, a lateral humerus. Let the patient move their body how they can, or not move their body if they can't. And this is when, as an x-ray tech, you get to get a little bit creative and figure out how to still get those required images while maintaining the patient's care and safety. So this is probably my favorite part of being an x-ray tech, is when you get that patient in and you're looking at them and they're